Good afternoon, everyone. Thanks for joining us today and spending a few minutes with us to talk a little bit about the ins and outs of stress testing. Hopefully this will take a little bit of the stress out of your life as it regards stress testing for you. I want to, first of all, review what we're going to be doing within the talk. We're going to talk a little bit about why we do stress tests. We're going to talk about different ways that we perform stress tests. And we're going to talk about the way that patient preparation plays a crucial role in getting accurate stress test results. To start off with, let's talk a little bit about why we do stress tests. And I'm going to start with a little example that doesn't have anything to do directly with stress tests, but help you clear your mind and think a little bit about why we do testing on patients. So if you think of Steve, no relation to me, obviously, but this Steve has been described by his neighbors as being shy and withdrawn. He's invariably helpful, but he has little interest in people or the real world of reality. He's a meek and trusting soul. He has a need for order and structure, and he has a passion for detail. So based upon what you know about Steve or what his neighbor knows about him, would you say that Steve is more likely to be A, a librarian, or B, a farmer? We're going to allow you to vote on this. Everybody had time to make their choice? Can we see the results of the polling? Okay. All right, very good. So actually, most of you picked the choice that he would be a farmer. And that's actually a very good choice because there are 20 times as many male farmers in the United States as there are male librarians. So this is important when we think about doing a test on a patient. We need to know what's the incidence or likelihood that a patient has a problem before we do a test, because that helps us interpret the results of the test. This is something that's based on work that was done by Thomas Bay, who was a Presbyterian minister back in the 1700s in England, who had a really strong interest in statistics and probability. And based on his work, we work with what's called Bayes' theorem. And Bayes' theorem tells us that if a patient, for example, has a low likelihood of having coronary disease or a low likelihood of being a librarian, even though he has a lot of characteristics that we might expect a librarian to have, there's still a relatively low probability that he's going to be a librarian because there just aren't that many male librarians around. And the same thing can be applied to stress testing. So when we think about pre-test probability of a patient having underlying coronary disease, we think about their history, we think about their risk factors, we think about what their EKG looks like, and we can divide people into groups that are at a low or very low risk of coronary disease, that don't have any real risk factors and have little or no symptoms, and a very high risk group which has a great number of risk factors or very typical symptoms of angina. And there's an intermediate group in between that. And if we look at Bayes' theorem, it'll tell us ahead of time we can stratify these patients based on their age, the demographics, the type of symptoms they have into these types of groups. So that, for example, if we have a gentleman who's 45, he's asymptomatic, doesn't have any real risk factors, he has a very low likelihood of having coronary disease. We can do a stress test on him, but even if the stress test is positive, he still has a very low likelihood of having coronary disease. On the other hand, if we have a gentleman who's older and has typical symptoms of angina, gets chest pain every time he walks up the hill to his garage, then we can do a stress test on him, but we already know the likelihood is very high that he has coronary disease. And even if he has a negative stress test, he still has a very high probability of having coronary disease. And that helps us decide when stress tests are appropriate. That's, for example, why we don't just do stress tests on everybody to look for disease we have to think about the situation itself and what the stress test is going to tell us. So there are many purposes we have for doing stress tests. The biggest one is assessing the risk of cardiovascular events or underlying coronary disease, but that can also help us determine a patient's long-term prognosis. And in some cases, when we're concerned about patients who might have multiple blockages in multiple spots, they can help us localize which area of the heart is actually causing the symptoms. They can help us make decisions about how to treat a patient, whether we're going to treat him with medication, whether we're going to be more invasive. They can also help us evaluate how well we're treating the patient, whether or not the medications that we started a patient on are really helping. They can help us determine what their exercise capacity is, maybe because they want to start a new, more vigorous exercise program or a different career, or maybe because they need to have surgery and we need to know that they can withstand the stress of surgery. And they can help us detect certain kinds of exercise-related rhythm problems that they may be complaining about. So when you look at the American Heart Association, American College of Cardiology indications for stress testing, these mirror those same types of criteria. So we have to think when we do a stress test, number one is, what are we trying to find out? What question are we trying to answer? That will help us decide whether a stress test is appropriate, and it'll also help us decide what type of stress test we need to do. Stress testing in general is better if we can have a patient exercise because it gives us a lot more information. But as we'll see as we go through the presentation today, some patients just aren't going to be able to do that. And we can still gain a lot of information from a non-stress or a pharmacologic stress test as well. So let's talk a little bit about different types of stress tests. Now, the oldest type of stress test we do is a treadmill exercise test. Over 100 years ago, it was noted that when patients had angina or chest pain coming from inadequate blood flow to the heart, they had changes on their EKG. And shortly thereafter, people began devising ways to put them through a stress test to look at their EKGs and see if they could mimic those types of changes. Now, when we have somebody walk on a treadmill, they're going to increase their heart rate, they're going to increase their blood pressure, they're going to increase the stress on their heart and the demands that we put on the heart muscles. So if they have a blockage, a significant blockage in an area of their heart, they may see changes on their EKG because of inadequate blood flow to that area. They may also develop the types of symptoms that they've been complaining about, chest pain, shortness of breath, or other things. And generally these days we use what's called a standard Bruce protocol, where we start a patient off walking at 1.7 miles per hour up at 10% grade. And then every 3 minutes we increase the speed and the incline of the treadmill until we reach the point where they either are too tired to go on or develop limiting symptoms, or they achieve 85% of their predicted maximal heart rate. And that's what we consider an optimal stress test. Now, generally, we'll ask to hold certain medications before a stress test. For example, we would prefer to hold beta blockers, and we would prefer to hold non-dihydropyridine calcium channel blockers. Why do we hold those? Because they limit the ability to increase our heart rate and make it harder to get to that 85% maximal predicted heart rate. And we generally will hold nitrates because they may mask the ischemia that's going on that we're looking for. So we can judge based on a stress test performance what a patient's prognosis is. For example, if they can walk through stage 4 of a Bruce protocol in 12 minutes on a treadmill and not have any significant problems, they have a less than 1% mortality from all causes, not just from heart attacks, but not even getting run over by a truck. Maybe they can outrun the truck if they can run that fast on the treadmill. But as we see these other factors, for example, decreased exercise tolerance, limiting symptoms, EKG changes, abnormal heart rhythms, they're associated with higher mortality rates. And this is why we use stress testing to help judge what a patient's prognosis will be. So this is a typical EKG you might see on a patient who has a positive stress test. You can see that in the inferior and lateral EKG leads, there are significant ST segment depressions. This particular patient did not have any significant chest pain, but he did have a positive stress test because of these EKG changes. There have been various kinds of indexes that have been developed, and one of the most common we use is the Duke Treadmill score, which is a combination of the patient's exercise duration along with the amount of ST deviation that's seen on the EKGs along with their angina. And by using this formula, we can divide patients into low, moderate, and high-risk categories depending on their stress test results. So the advantages of a treadmill stress test are that it's readily available. It's very good for patients who are at intermediate risk for coronary disease, as we looked on diagrams from Reverend Bay. And it's usually a very inexpensive test and easy to do. The disadvantages are it's not very good in patients who have abnormal EKGs, and it's not very good in patients that can't walk on a treadmill. So those are its limitations. There are some absolute contraindications to exercise stress testing as listed here. For example, if someone's had a recent heart attack, we don't feel it's safe to put them on a treadmill. If they're having unstable angina, if they're having chest pain at rest, it's generally not wise to put them on a treadmill and try to see if we can make them have more chest pain. If they have bad aortic stenosis, if they have active dissection, or if they simply have some physical disability that would limit their ability to walk on a treadmill without hurting themselves, then those would be absolute contraindications. In addition, there's several relative contraindications. Prominent ones we see often are markedly elevated blood pressure, because blood pressure will elevate further as we will have them walk on a treadmill, abnormal heart rhythms, abnormal metabolic problems that'll predispose them to certain kinds of rhythm issues are considered relative contraindications to exercise stress testing. So moving from that, we move to another level of stress testing, and we say, well, sometimes patients can have false negative stress tests, and that's because there may be areas of the heart that are relatively electrically silent. So they may have ischemia in an area of a heart that's not going to show up on a treadmill or not going to show up on their EKG. In addition, the treadmill is very poor at localizing where ischemia is in the heart. We get a general idea, anterior wall, inferior wall, lateral wall, but it's not very good or predictable in determining what area of the heart is actually involved with ischemia. So we have the ability to do a treadmill echo exam, and in that exam we generally take the patient first and we do an echo to look at the heart function in 4 different views so we can see all of the different walls of the left ventricle. We then put them through a normal stress test, again using a Bruce protocol with trying to achieve 85% of predicted maximal heart rate. And then within 60 seconds after getting them off the treadmill, we take another set of pictures with an echo machine to look and see whether or not the heart function is doing better or whether, in fact, it's doing worse with exercise. So these are some static pictures that you can see from a stress echo examination. And you can see on the first line and the third line are resting images in 4 different views. And in each of those paired views, you see diastole and systole, so the heart at rest and the heart when it's beating. And you can see on the first and the third lines in all of those 4 views, there is a marked decrease in the size of the left ventricular cavity, and there's thickening of the left ventricle wall in all of those views. Now compare that to the images on lines 2 and line 4 where we're stressing a patient, and instead of seeing normal contractility of the heart in this patient, you can barely tell the difference between diastole and systole, and that's because this heart is ischemic. It's not contracting normally, and under conditions of stress, it's not able to contract in a normal fashion because the walls are ischemic. So this would be a markedly positive stress echo examination. In fact, when you look at the parasternal short axis views on the bottom line, the last 2 panels on the right on the bottom line, you can barely tell the difference between diastole and systole because the apex is almost akinetic due to ischemia. So the advantages, again, to a stress echo examination is, again, it's readily available, it's relatively inexpensive, and it allows us to look not only as a positive or negative test, but also lets us localize the area of the heart that may be involved. It's more sensitive than a treadmill examination picking up ischemia, and it's also more specific. The limitations are that not all patients are easy to image with echo machines, and it requires a very experienced echocardiographer to be able to image the patient within that 60 seconds while their heart is maximally stressed and their heart rate is still elevated. Again, not all patients are going to be able to walk on a treadmill, and that's a potential problem as well. So we've developed other schemes where we can do different types of stress tests with patients who are not able to adequately walk on a treadmill. So getting back again to the stress echo examination, we can use dobutamine, which has can be infused IV in a patient and has both positive chronotropic and inotropic effects. It makes the heart beat faster, and it makes the heart beat more forcefully. So it mimics exercise in a patient. And so we can take echo images. We can then have the patient lie on a table and infuse dobutamine through an IV, first at very low doses, and then every 3 minutes increasing the dose sequentially to higher doses, just as we would have them walk on a treadmill at higher and higher levels of exercise. Again, our goal is to try to reach 85% of predicted maximal heart rate. And in those patients who we cannot get to a maximal heart rate even at a higher dose of dobutamine, we sometimes will give them IV atropine to further increase their heart rate. Once we get their heart rate to the maximum response that we're looking for, then we would re-image them with the echo machine and look to see whether or not we were increasing the contractility, or as in the last patient, whether we're showing a dysfunctional left ventricle due to ischemia. So the advantages to this, obviously, is it's very good for patients who can't walk on a treadmill. Maybe they're too short of breath. Maybe they have peripheral vascular disease. Maybe they have severe limiting arthritis or back problems that prevent them from walking on a treadmill. Maybe they've even had amputations. The disadvantages are that the medication itself, dobutamine, can have some serious side effects. They're very small in terms of the incidence, but they do happen, and you have to be vigilant for this. And that's why someone with ACLS training needs to be watching these patients at all time during the procedure to make sure that if problems do develop, that we can treat them promptly. Again, the other limitation to echocardiography in general for stress testing would be the ability to get good images and having a very experienced sonographer able to obtain those images in a very short period of time while the heart is maximally stressed. Now, these are pictures from a paper that was published in the 1970s by Dr. Zaret. Dr. Zaret and I worked together for several years, and he was one of the first people to describe nuclear imaging in cardiology. These are very grainy pictures, and you can kind of see a blob there that maybe looks like the heart. These images were obtained with radioactive potassium, which was the first imaging agent that was used for the heart. And you can see it again, it's very grainy, and that's because that radioactive potassium has a very low energy level. And so it was not an optimal an imaging agent to use in this kind of setting, but it was the first imaging agent used. Since then, we've come a little bit further. And so the next agent that was used that's represented on these pictures with a T was thallium. Thallium is a radioactive isotope which is almost the same size as potassium. So it binds to the sodium-potassium ATPase pump in the cell membrane and is actively pumped into cardiac cells just like potassium would be. So by accumulating this radioactive agent inside a cell, you were able to image the myocardial cells with a nuclear camera. So that meant that if you had a viable myocardial cell, one that had not been damaged by a previous heart attack, and you had adequate blood flow to that area of the heart, you should get good uptake of tracer activity in the cell, and you should get good imaging. The two things that would prevent imaging of that cell would be either that you have a blockage in the blood flow to that area, so the tracer is not able to reach the cell, or you have a cell that's been damaged, and therefore it's not metabolically active, and it cannot transport the thallium into the cell. So it's a very good physiologic agent for looking at viability and of flow delivery to cells in the heart. The reason we don't use thallium as much anymore is, again, the same reason we don't use potassium. Even though it was a better imaging agent, even better imaging agents came along. And technetium-99m is generally used in a variety of forms to do this imaging today because it has superior imaging characteristics. It has a higher level of imaging of energy, so it's able to be imaged in smaller amounts of time and with less signal to noise, so that we can have a better image of the heart and less grainy pictures and be able to have prettier shots that are easier to interpret. Now, it works a little bit differently. It non-specifically crosses the cell membrane, and it actually binds to the mitochondria in myocardial cells. And the mitochondria are going to be very active while you're stressing a patient because the cell is going to be metabolically active. And so, again, the limiting factors would be either you're not having enough blood flow to the cell because the artery is blocked, or you may have a cell that's damaged from a previous heart attack. And in those cases, that cell is not going to light up normally. So the protocols for using this type of imaging agent is generally we tend to inject patients with an isotope. We take a picture of their heart at rest. And then at some point after that, we exercise the patient. While the patient is on the treadmill, again, on a Bruce protocol, trying to achieve that 85% predicted maximal heart rate, we're going to inject them with a second dose of the nuclear isotope at peak exercise. Then after a short delay, we're going to re-image the patient, and then we're going to compare the two sets of pictures, the pictures that were taken when the patient was resting and the pictures that were taken when the patient was fully exercising. Alternatively, if the patient cannot walk on a treadmill, we often use a vasodilator. Now, the most common one we use these days is Lexiscan. There have been many others that have been used along the way. But the principle is the same for all of them. The idea is that if we can maximally dilate the arteries to the heart, then we're going to increase the flow of that radioisotope to the myocardial cells. And we can do that without having to put a patient through an exercise protocol. Now, Lexiscan, adenosine, persantine are all fairly similar. They all bind to adenosine receptors that are located on the cells lining the blood vessels that go to the heart, the coronary arteries. And so on the endothelial surface are many of these receptors, and by binding to these receptors, they cause the artery to dilate. Now, there's certain things that can interfere with these medications binding to the receptors. Most common ones are caffeine, that you can see on the picture here as a C, or the methylxanthines, which are other components of coffees and teas, for example, that can actually block the agent from binding to those receptors. So that's why we always say you can't have coffee on the day of your exam, you can't eat breakfast because that's going to screw up your imaging. Now, you can also see that adenosine and these similar analogs will also bind to other receptors, some of which can cause bronchoconstriction. And so sometimes in COPD patients, this can be a problem. It's not as much of a problem with Lexiscan as it is with adenosine, and that's one reason why we prefer to use Lexiscan, because it doesn't bind to those receptors as well. There are other adenosine receptors that can bind to, which can cause high-grade heart block. And so again, in patients who have pre-existing heart block or bradycardia, we tend not to want to use these agents because they can exacerbate that problem during the test. Usually these things are all easily reversible and quickly reversible, but we'd like to avoid them if we can. So if you look at the center panel here, what we're seeing is sort of a graphical depiction. You can think of the blood flowing through the left main artery coming from the top of that center panel, going to the left-hand side, which might be the left circumflex artery, which doesn't have any stenosis in it, and compare that to the flow into the right side of that bifurcation where you have the left anterior descending artery that has a blockage in it. So you're going to have more blood flow going in the distribution of the left circumflex artery, less blood flow going in the direction of the LAD. Now on the right-hand panel, if you give an agent like Lexiscan that causes arteries to dilate, the normal artery, in this case the left circumflex artery, is going to be able to dilate. The left anterior descending artery is not going to be able to dilate because it's blocked. It has an obstruction. And so now you see there's even a greater disparity of blood flow between those two areas. That's what allows us to see the differences that we see on a nuclear stress test when we use a vasodilator like Lexiscan. On the left-hand panel, you can see that there's a problem when patients are on nitrates because the nitrates will allow better flow through the collateral vessels from the undiseased vessel to the diseased vessel. So we may lose that benefit of seeing a differential blood flow to those two areas if the patient is taking nitrates. And that's why we always ask that you hold nitrates before a procedure when you can, because it may obscure problems that will actually be present and we may not be able to see them. So indications for pharmacologic stress testing using a nuclear isotope would be someone who has an abnormal baseline EKG, for example, so they're not going to be good for a treadmill ECG exam. Or if they have an inability to exercise on a treadmill at all, then we have to think about a chemical agent like Lexiscan. We're going to tailor this towards patients who, again, have an intermediate probability of disease. Those with a low risk of disease are not likely to have disease, even if this test shows a mild abnormality. So you can see here a normal set of images from a myocardial perfusion scan. And to describe this to you, on the top two lines are what we see the parasternal short axis view. And this would be what you would think of if you laid the heart out on a table and you sliced it from the tip to the top of the heart like a loaf of bread. And what you should see are small circles. So on the left-hand side, near the tip of the heart, the circles are going to be small. And on the right-hand side, as you get higher up in the heart, toward the base of the heart, the circles are going to be larger because that's the shape of the left ventricle. And what you can see here looks like a perfect circle where you have uniform orange activity of the nuclear isotope throughout all of the myocardium. On the next two lines further down, the third and fourth line, you're going to see a long axis view of the heart. And you can see here you're slicing that loaf of bread in a different dimension. So now you're on the left-hand side, you're seeing the ventricle toward the septum. In the right-hand side, you're seeing toward the lateral wall. And you can see it looks like a horseshoe that's laying on its side. And on the top of it is going to be the front wall or the anterior wall of the heart. On the bottom is going to be the inferior wall of the heart. And out at the tip of the horseshoe is going to be the apex or the tip of the heart. And then on the bottom set of views, you can see, again, we can slice the heart in a different way. And in this view, you're going to see the anterior wall towards the left-hand side of the screen, the inferior wall towards the right-hand side of the screen. And in the middle, you're going to see the septum is going to be to the left, the lateral wall is going to be to the right, and the apex is going to be at the top. So this allows us to look at all of the walls in different views so we can localize where we might be seeing a problem. Again, this is a normal study. We see uniform distribution, radioactivity throughout all of the walls of the heart, and so this would be a normal myocardial perfusion study. Now compare that with this. On the top row of each of these pairs, you're seeing a patient who has either exercised or received a Lexiscan, and on the bottom of each of these pairs, you're seeing the resting imaging, and you can see there's a marked difference. So if you look at the top two set of images, if you think of the parasternal views, you can see that the resting view looks a little bit like a donut. The top images look like somebody's taken a really big bite out of the donut, and that's because that area in the septum and the inferior wall is not receiving good blood flow because there's an obstruction of blood flow there. Now, we know that it's not an area of scar because we know when we looked at the resting images on that second line, for example, that we see uniform tracer activity throughout the heart. If those cells were damaged or scarred, we wouldn't see that. So this is a classic example of myocardial ischemia, in this case involving most of the inferior wall and the apex, and this would be something we would think of as a tightly blocked right coronary artery that wraps around the apex, having a significant blockage in it. Compare that again to this set of pictures where we see both the first and the second set of images in each pair show a significant defect where you're not having myocardial uptake in this case the anterior wall and the apex, but that's matched on both the stress images and the rest images. So this is an example of myocardial scar. There's not necessarily a problem with blood flow to this part of the heart. There's a problem with the fact that the myocardium here has been damaged from a previous heart attack. So this is an area where even if we were to reestablish blood flow to this area of the heart, we're not likely to see a benefit to the patient because the area has already been permanently damaged from a previous heart attack. So again, in these studies, patient preparation is extremely important. These patients should be fasting. They should avoid caffeine because that can interfere with binding of agents to the myocardium. They should avoid other caffeine-containing medications. They should avoid nitrates. If you're doing a stress test on the patient on a treadmill and getting nuclear imaging, then again, you want to avoid beta blockers or the non-dihydropyridine calcium channel blockers so that we can get them up to an adequate heart rate. And of course, in this, as in all tests, you have to have good IV access for the patient so that we're able to inject them with the agents we need in order to image them. So I'm going to give you another polling question now. We have a patient, Mary, who's scheduled for a Lexiscan stress test this morning. Should we A, hold her nitrates, B, hold her Plavix, C, hold her breakfast, D, all of the above, or E, A and C only? And I'll give you a few minutes to look at that and give us your answer. All right, get your answers in. And let's get ready to close our polling. Okay, very good. So in this case, we definitely want to hold her nitrates because we've shown that that can interfere with our ability to detect ischemia. We definitely want to hold her breakfast because that can interfere with our ability to image the heart. But there's really no reason to hold her Plavix, which is a blood thinner. It's not going to interfere with our imaging. And if she has a stent that's been recently put in, for example, we'd rather not hold her Plavix. So in this case, the correct answer is going to be E, which is hold her nitrates and hold her breakfast. All right, let's talk again a little bit about the importance of preparation of the patient for stress testing. This is an interesting study that was published a couple of years ago. And on the top of the line that you see on the screen, you're going to see a patient who was given a normal Lexiscan stress test, or in this case, they used dipridamole instead of Lexiscan, but similar agent. And on the bottom line, you're going to see the resting imaging of that patient. So again, as we talked about, and you're now expert readers in all of this, you can see as though someone has taken a bite out of this heart, and there's an area there on the apex, on the anterior wall, and a little bit on the distal inferior wall of the heart on the top line, which is not filling in normally. And it does fill in normally on the rest images, so that tells us that we've got a significant area of ischemia. But they took this same patient and they imaged them on a different day, and that time they gave them either a low dose or a high dose of beta blockers. And those are the pictures you see on the second and the third line. And you can see by giving them beta blockers before you did the stress test, you almost totally obscure the defect that's seen. And so it's very, very important. It's when we talk about holding these medications and preparing the patient appropriately for a stress test, it's not just because of some arbitrary standard. It's because it really makes a difference in whether or not these tests are going to be accurate and are going to be interpretable for the patient. If we don't prep the patient correctly, then we're wasting their time and their money to do the test, and we may come up with an erroneous result. Okay. So this is a cascade that's used by a lot of insurance companies, including Medicare, for deciding when we can do nuclear stress tests and when we can't. And the bottom line is that if someone can get an answer with a normal treadmill examination because they've got a normal EKG to begin with, then that's going to be your preferred method. And nuclear stress testing should be reserved either for people who have an abnormal EKG or for people who can't walk on a treadmill and we need an imaging agent in order to be able to look at their heart after pharmacologic stress. Or if they have a specific incidence where they've had previous bypass surgery or previous stent placement, then nuclear imaging is going to be a superior mode to look at them for stress testing in order to see if they have residual areas of ischemia. The reason it's superior is it can more directly localize where the ischemia is. We can see if it's in an area where they've had a previous stent or if it's a different area of the heart. we can see whether it's an area they've had a previous bypass. So when we go to insurance companies and we say we want to do a stress test on Mr. Jones, these are the kind of questions that they ask us in order to justify the added expense and the added costs of doing these types of procedures. Of course, we're always trying to develop better and newer ways to do stress testing, and we have to keep working on that as well. So when we think about types of stress tests that we can do, if a patient's able to exercise, that's always going to be our preferred mode, unless they have a markedly abnormal EKG to begin with. So that will mean a treadmill exam if it's an EKG that's easy to interpret. If the EKG can't be interpreted or we need more specific localization of where the ischemia is, then we look to echo imaging with a treadmill exam or with nuclear stress testing with a treadmill exam. On the other hand, if a patient cannot exercise, then we have options of a dobutamine echo examination, or we have option of doing a nuclear stress test with a vasodilator. Most common one that we use here is Lexiscan. Now you can see that as we go up from the cascade of exercise testing to exercise with echo and then exercise with nuclear imaging, we improve our sensitivity and we improve our specificity, but we also improve our costs. So again, we have to be good stewards of our resources, and we have to realize that that extra cost has to be of extra benefit to the patient, and that's why we have to carefully select the type of stress test that we're going to do on a given patient. All right, this is going to be our last polling question, and then we're going to open it up to questions from you guys. So we have a patient, John, who comes to the emergency room with chest pain. He's 45 years old. He has a history of hypertension. He had some pain that occurred over his left breast while he was driving his truck. It went away all by itself in about 20 minutes, and he came to the EKG. He came to the emergency room, rather, and his EKG showed us a left bundle branch block. His labs, including his troponin levels, were all normal. And now we've decided that we need to do some additional testing to figure out whether or not this chest pain is something that John and we need to worry about. So these are our options that are before us. Do we put John on a treadmill and do a standard stress test? Or B, do we do a stress echo examination? C, do we do a Lexiscan stress test? Or D, do we take the patient and do a cardiac cath on him? And we'll open this up for polling again. Everybody made their choice? Okay. So we know that John has a left bundle branch block on his EKG. So we know that doing a standard treadmill stress test is not going to be probably our best choice. The reason for that is that the left bundle branch block is going to make his EKG look abnormal to begin with. And when we put him on a treadmill and exercise him, it's going to look even worse. So that's not going to give us a diagnosis based on EKG alone. The second option would be doing a stress echo. And the stress echo might be a good choice for patients who have certain types of EKG abnormalities, but a left bundle branch block not only makes the EKG look funny, but it also makes the contractility of the heart look funny, so that the septum and anterior wall often don't seem to contract with the rest of the heart at the same time and can look like there's a wall motion abnormality there. So a stress echo exam is also not going to be our best choice. Cardiac cath is always an option, but John is not in a high-risk group based upon his demographics, his age, the atypical nature of his chest pain. A cardiac cath is generally not something we're going to leap right to because it's an invasive study. So the best choice out of this group is going to be a Lexiscan stress test, because the Lexiscan is going to allow us to image his heart with a nuclear isotope that's not going to be affected by his abnormal EKG, and not going to be affected in large measure by his left bundle branch block either. So that would be our best choice. So I appreciate you spending some time with us here today. I'd like to open it up to questions for you, and I think Tracy has it set up so that you can type in questions to us, and we'll try to respond to them as many questions as we can. Please feel free to ask if there's any gaps or any things that I glossed over that you'd like to go into further. Also, at the bottom of the slide, you'll see a link to a site that we'd like you all to go to fill out a brief survey to let us know not only how you felt about this talk, but also to get ideas for future talks that you'd like to hear among cardiology issues or among other issues in medicine in general. And by entering and completing that survey, you'll also be entered into a raffle for a $25 gift certificate from our Nardello's. So we encourage you all to click on the link and to also fill out our survey. All right. Any other questions for us today? If not, I'll thank you all for coming. We appreciate your attention, and we hope that you'll be able to put this in your everyday practice. Thanks.